right. Hello and welcome, everyone. Thank you for those of you who are able to join us today. We're joined today by Dr. Mitchell Onwochei. She's a neurointensivist and adult medical intensivist, and is driven by a central mission to improve patient outcomes and provide support to families during their loved ones' care. She's committed to continually enhancing the ICU environment, striving for a greater humanity in critical care. Her professional interests span hemodynamics, neurological preservation, point-of-care ultrasonography, and palliative care medicine. Today, she is joining us to present on fluid responsiveness. So thank you so much for joining us today, Dr. Onwochei, and I'll hand it over to you for your presentation.
Thank you. Thank you, Amanda, for that introduction. Just like she said, I'm Michelle Onwochei. I am an intensivist. I practice at Innova in Northern Virginia in the US. And I do have a specialization in neurocritical care as well. I am originally from Nigeria, West Africa. So given this talk, hits close to home for me, this is a very gratifying opportunity. And I'd like to thank the Johns Hopkins University, St. Paul's Medical College, and KBTH for organizing this. I hope to see more of this. I hope it's widespread and we see more of this. All right, so now on to my talk. I'm going to be talking about fluid responsiveness. I have no disclosures that are relevant to this talk. And these are my learning objectives. I will be talking about fluid responsiveness, the definition of fluid responsiveness, why it is relevant, how to evaluate for fluid responsiveness, and what hemodynamic variables to measure when evaluating for fluid responsiveness. I also will very briefly touch on tissue perfusion, as some clinicians are recommending we move towards using tissue perfusion as a guide to monitor fluid responsiveness. And we will go over a few knowledge check questions, and I will end with a summary. So what is fluid responsiveness? It is defined as an increase in cardiac output of 10 to 15% after intravascular volume expansion. And why is it relevant? It's relevant because you want to be able to optimize hemodynamics in critically ill patients while avoiding fluid overload. Some studies have shown that only 50% of critically ill patients are fluid responsive, yet a larger percentage of these patients get fluids. And the concern with that is having patients develop hypervolemia from getting fluids when they are not fluid responsive. So on the right of your screen is your Frank-Starling curve. The goal is to find patients in the bottom part of the curve, so the hypovolemia section. You want to be able to give a certain amount of preload and know that that will result in an adequate increase in stroke volume and in cardiac output. So your goal really is to get them to normal volemia and prevent hypervolemia, which we now know causes multi-organ failure from tissue parenchymal edema and causes worsening mortality and morbidity. So how can we evaluate for fluid responsiveness? I will talk about the previous gold standards for evaluating for fluid responsiveness. Those were your pulmonary artery catheter, CVP monitoring, and then we'll talk about novel technologies that are now available. And again, briefly talk about tissue perfusion. So previous gold standards were your Swan-Ganz, that's your pulmonary artery catheter, and central venous pressure monitoring. With your pulmonary artery catheter, you would insert your catheter through the chambers of your heart on the right side. So you would start with your right atrium, and this is the waveform you should see at the bottom here. And then you would advance to your right ventricle, and you should see the pressure jump up, and the waveform should look like this. And with more advancement, with your balloon up, you should get to your main pulmonary artery, and this is what the waveform should look like. And with further advancement, you would get your you should get into one of the branches of the pulmonary artery. And with your balloon occluded, the pressure you get there is your pulmonary artery wedge. Now, because the balloon is occluded and start to occlude the whole vessel, the thinking is that the pressure you get there should correlate closely to your left atrial pressure. And in addition to getting your filling pressures, you can also get your cardiac output from your pulmonary artery catheter. You can, with the means of thermodilution, you can get your cardiac output. And the way it works is you inject cold saline into your proximal port, and you check the change in temperature at the distal end of your pulmonary artery catheter. And you plug that difference, it automatically does it for you. It plugs it into this equation down here and pretty much calculates the area under the curve, and that gives you your cardiac output. So this is a measure that has been well validated by multiple studies. You can also get your cardiac output by doing the Fick's principle. This is a principle that was developed by Dr. Adolf Fick in the 1800s, and you get it by dividing your tissue oxygen consumption by your arteriovenous oxygen difference. And your tissue oxygen consumption is estimated to be 125 times your body surface area. And your blood oxygen content is this equation below, which I hope you guys get frequently quizzed on this, like I did when I was in training. And again, this is just saying all the measurements you could get with your pulmonary artery catheter. You get your CVP, you get your right-sided pressures, your wedge pressure, your pulmonary artery pressure, your cardiac output, your mixed venous oxygen, and you get some indirect measurements like your SVR, which is 80 times MAP minus your CVP divided by cardiac output. You get your pulmonary vascular resistance, which is 80 times your mean MAP minus your wedge divided by cardiac output. You can get your cardiac index as well as stroke volume index. And it sounds really great. It sounds like you can get all these values, and by so doing, find ways to manage your patients. Because if you have a patient in shock, you want to know what type of shock is this and how should I manage this patient? And I want you guys to go through the slide with me. I want you guys to think of what the answer should be before I show it on the screen. If it's in hypovolemic shock, what do you expect your CVP to be? It should be low. And your wedge should be low. Your SVR should be high. And your cardiac output should be low. And now with cardiogenic shock, think of what you think your CVP should be. It's expected to be high. Your wedge is usually high. And your SVR is high as well. And your cardiac output should be low. And with obstructive shock, what do you think your CVP should be? It should be high. And what about your wedge? What do you think it should be? So this is tricky. It's usually low. So in things like an acute massive PE, your right ventricle is blown, but your left ventricle is spared. And if anything, it's hyperdynamic. So you'll see your left ventricle squeezing away, and the wedge is usually low. But in obstructive shock that's caused by cardiac tamponade, all the filling pressures of the chambers are elevated. So your wedge will be elevated there. And your SVR is usually high in obstructive shock, and the cardiac output is low. And lastly, with distributive shock, your CVP is usually low. And what about your wedge? It's tricky as well. It's usually low, but it could be high. Some studies have shown that about 20% of patients with ARDS and septic shock have elevated wedges. So it could be high. And your SVR is usually low. So this is the one time you'd find a low SVR and a high cardiac output. So again, like I said, it sounds great. You can get your numbers, you can see how to manage patients and improve mortality. However, when this was actually studied and evaluated, they found that the use of pulmonary artery catheter does not result in improved mortality and morbidity. So in the late 1990s and early 2000s, multiple studies were done. This is just one of such studies. and they found no improved mortality when using pulmonary artery catheters to guide your management. And this is a meta-analysis of multiple studies that were done, which again showed no mortality benefits when using swans and no improvement in the number of days hospitalized. Some studies actually showed worsening outcomes when using swans, and the thinking behind that is that it was as a result of complications from swan placements. So clinicians then started to move away from swan placements. It used to be the gold standard that every critically ill patient will get a swan placed. However, when the studies were published, physicians started moving away from it because if you have a complication during insertion, you could have arrhythmias, you could have misplacement. I'm sorry, 1 second. Let's see what. I'm sorry. Yeah, you can have misplacement, you can have myocardial vessel or valve rupture. And even when your swan is inserted, with maintenance, you could have your pulmonary artery perforated. So when trying to wedge and you blow up your balloon, you could perforate your pulmonary artery. You can have thromboembolism, you can have infections. And also with interpretations, lots of studies have shown wide inter-observer variability. So clinicians felt it wasn't worth the risk for this to be the gold standard of care. And in the late 1990s, physicians, well, I should say clinicians then moved towards a less invasive form of hemodynamic monitoring, which is your central venous pressure monitoring. And this requires a central line to be placed in your cavo-atrial junction, so it doesn't go through the chambers in your heart. It just stays there by the right atrium and SVC junction. And with that, you can get your central venous pressure, and you can get your central venous oxygen, which is thought to correlate with your mixed venous oxygen that you will get with a pulmonary artery catheter. And in 2001, Dr. Rivers published a study on early goal-directed therapy in the treatment of severe sepsis and septic shock. So he would take patients who presented to his emergency room in septic shock, and within 6 hours, place a central line and go through this algorithm. So they will check the CVP. If it was less than 8, they would assume patients are hypovolemic. They would give crystalloids and colloids until they got a CVP of 8 to 12. And when that was obtained, they would then look at the MAP. If the MAP was less than 65, they will start vasopressors. If the MAP was greater than 90, they will start vasodilator therapy until they obtain the goal of MAP of 65, between 65 to 90. And once that goal was achieved, they would then look at the central venous oxygen. And if that's less than 70, they would assume that your arterial oxygen content is low, and they will transfuse red blood cells until the hematocrit was greater than 30%. Once that was achieved, if your central venous oxygen still remained low, they would assume that that's a pump failure, and they will start inotropic agents until they got a central venous oxygen of 70% or greater. So they compared patients who went through this algorithm versus patients who were managed, which is the standard of care, which was looking for a MAP greater than 65, a urine output of 0.5 mL per kilogram per hour, and a CVP of 8 to 12. And he found that there was improved mortality in those who went through early goal-directed therapy. The mortality was 30.5% versus 46.5% in those who underwent standard therapy. The 28-day mortality was 33.3% versus 49.2%, and the 60-day mortality was 44.3% versus 56.9%. So he concluded that early goal-directed therapy provides significant benefits with respect to outcome in patients with severe sepsis and septic shock. And this then became the standard of care. Most critically ill patients will get a central venous line placed in, and they will go through that algorithm. And that was until 2014 and 2015 when 3 independent multi-center randomized controlled trials were done. The ARISE, PROCESS, and PROMISE trials, which showed no improved outcome in critically ill patients when managed with early goal-directed therapy. So Dr. Rivers' study was a single center study, and these 3 studies were multiple centers. And this is the ARISE study, which showed that in critically ill patients, the outcomes were pretty much similar in whether or not you went through the algorithm focused on early goal-directed therapy versus usual standard of care. And the PROCESS study showed the same as well, that protocol-based resuscitation in patients with septic shock had the same outcomes as, as those who underwent standard of care. And the PROMISE study was released in 2015. Again, it showed the same, that the usual care was equivalent to early goal-directed therapy. So they concluded that strict hemodynamic monitoring does not improve mortality or morbidity. However, they did feel that Dr. Rivers' study showed improved outcomes because it helped enhance the way patients were managed. Because of his study, the thinking is that patients got volume resuscitation earlier than they would have, and that patients got antibiotics earlier than they would have. So they thought that resulted in improved outcomes, and it wasn't necessarily the hemodynamic monitoring. So after these studies were released, then clinicians started to move away from central venous catheter placements to obtain CVPs and central venous oxygen. And again, because central venous catheters also, you do have complications with them. You could have arrhythmias, you could have injury to your vascular structures, you can have infections, pneumothoraces, thromboembolisms, and there's also poor inter-observer reliability. So in summary, most clinicians, most experts recommend that you reserve the use of invasive hemodynamic monitoring for selected patients. So patients with undifferentiated shock. There are going to be some patients where you just can't tell what their volume status is and why they're in shock. And this is despite a thorough physical exam and despite your echo, you just can't tell. So in such patients, I place swans in, or I perform invasive hemodynamic monitoring, and experts recommend you do as well. Also, in patients with severe cardiogenic shock, the invasive hemodynamic monitoring could be helpful. It could guide you with titration of your inotropic agents. And also, I find it helpful in patients who have pulmonary artery hypertension, as well as severe underlying cardiopulmonary diseases, such as congenital heart disease or severe valvular disease. So now we can talk about novel tools for hemodynamic monitoring. And they're mostly minimally invasive or non-invasive. There are lots of them out there. I'm only going to talk about a few because otherwise it would take me the whole day to go through each one of them. So I'm just going to talk about the more common ones. So an invasive one is PICO. It requires you to place a central line in your cavo-atrial junction, so between your right atrium and your SVC. And it also requires an arterial line, and the recommendation is a femoral artery line. And there's minimally invasive FlowTrack Vigileo, which just requires an arterial line. I have a decent amount of experience with Vigileo. And there's a transesophageal echocardiography, which most will say is minimally invasive. And regarding non-invasive, there's a NICOM Cheetah, which uses electric bioreactants, your ClearSight systems, and there's point-of-care ultrasonography, which is certainly my favorite. So let's talk about PICO. PICO, like I said, it requires a central line in your cavo-atrial junction and an arterial line, preferably your femoral artery. And you perform thermodilution just like you would with the pulmonary artery catheter. You inject cold saline into your SVC, and you measure the temperature change in your femoral artery. And you plug that into this formula and pretty much calculate the area under the curve, and that gives you your stroke volume. And once you have your stroke volume, you see that you can have your cardiac output. It's stroke volume times your heart rate. So a limitation to this is that it's invasive. It's not any less invasive than a central venous catheter. So that's one of the limitations to it. But you can get other variables. You can get you can get more hemodynamic variables than you would with the central venous catheter. And minimally invasive is your flow track, Vigilayer, which uses arterial pressure waveform. So with this, you just need a radial line, I'm sorry, an arterial line, and you get your arterial pressure waveform, and you calculate the area under the curve, and that gives you your stroke volume, and you can get your cardiac output from it by multiplying your stroke volume with your heart rate. That gives you your cardiac output. You can also get other variables like your stroke volume variation, which we will talk about later. Limitations to this is that in patients with low flow or poor perfusion, it's not as accurate. And another minimally invasive is your transesophageal echocardiography. And if it's a transthoracic echocardiography, that is completely non-invasive. So with this, you want to look at your left ventricular outflow tract. And if you can see on the slide here, that's the part where your left ventricle empties into your aorta. So this is your TE view, and down here is your parasternal long axis on your TTE view. And you want to measure the diameter of that area and get the radius and then obtain the area, the cross-sectional area. So that will be pi r squared. And then you want to get your VTI. So using pulse wave Doppler, you get this waveform, which some echoes calculated automatically for you. And for others, you actually have to do a manual measurement. So that gives you your velocity time integral. Your VTI times your cross-sectional area gives you your stroke volume. And your stroke volume times your heart rate gives you your cardiac output. And limitations to this is that it's user dependent. You have to undergo a series of training to be able to do it. And it's time consuming. So I do it quite often. I love doing it. I enjoy it. You can learn a lot about a patient when you do it. However, on a busy day, it's really, really hard to do it. You have to position the patient, make sure you get the right windows. So that's a big limitation, is that it could be time consuming. And it's been validated by multiple studies. This is just one of such studies that non-cardiologists, non-sonographers can get accurate measurements. So the cardiac index that non-cardiologists and non-sonographers get correlate closely with the numbers that sonographers and cardiologists obtain. So as a critical care physician, you should be able to do it after you've undergone the training for echoes. And another non-invasive one is your Cheetah/NICOM system, which uses electric bioreactance analysis. And it's based on electrical resistivity. So you pretty much apply 2 dual electrodes on the upper torso of your chest wall and 2 on the lower part of your chest wall. And you apply an electrical stimulus. And then you measure the time delay between the 2 signals, and that's called the phase shift. And that is imputed into this formula at the bottom, which then gives you your stroke volume and therefore your cardiac output. And a limitation to this is that, oh, my slide's frozen. Oh, my slide is frozen. Oh, there we go. I'm not sure what happened. Let's see, 1 second. My slide is frozen. Not sure what's going on. I can't seem to go to the next slide. Strange.
Yeah, do you want to try going out of presenter mode.
Going out of presenter mode, sure. Let's see how to do that. Full screen. I don't think that's working for me. Let me see. Maybe I should stop sharing and start again.
Sure, yeah.
See if it works. Okay, I think, yeah, now it's working. Okay. So a limitation to this is that you do have signal interference from anything that can provide an electrical stimulus. So things like electrocautery can cause signal interference, and it's also inaccurate in cases of low flow. And with non-invasive as well, you have a Clear-Sight system, which measures your finger arterial pressure via an inflatable cuff. So just like you would measure your blood pressure with a regular sphygmomanometer, which measures your brachial arterial pulse, the Clear-Sight measures your finger arterial pulse, your finger arterial blood pressure. So this circle here is a cross-sectional area of what your finger should look like. You usually use your intermediate phalanx. And if you can see, there's a light source applied and the light detector. It measures the changes in the volume of the artery. So the red dots are your arteries in your finger, and it measures as the artery is pulsatile, this measures the changes in the volume. And then it uses another complex method called the physiocal method, as well as your pulse contour method, and that gives you your stroke volume. And by so doing, you have your cardiac output. So it's very complex, and I'm pretty much giving a very simplified explanation of how it works. The limitation here is that it's inaccurate in low flow and in peripheral vascular disease. So why are these not the standard of care? They're non-invasive, and they're mostly non-invasive, and you can get a lot of variables from them. But the reason is that it has a lot of limitations. It has most of them have complex algorithms, and it's hard to interpret. And because of the complex algorithms, it's hard to validate as to whether or not the values you get are accurate. There are also no large randomized control trials that have been done on them so far. This slide does show you multiple studies that have been done. Most of them were retrospective studies or small studies. So no large, strong RCTs have been done. And the results here on most of the studies were inconsistent. So some showed that they correlated with the numbers you would get from a pulmonary artery catheter, and others showed that they were not consistent. So the way I use them and the way most experts recommend you use them is by trending the values you get. So let's say you place in a flow track, you have an arterial line, and your flow track Vigileo system is telling you the cardiac output is 5. I don't necessarily believe that the cardiac output is 5. However, if that cardiac output then drops to 3, I then start worrying about heart failure. Why is my cardiac output dropping? So going by the trend is more helpful than going by the absolute numbers you get from these tools. So far we've talked about fluid responsiveness, its definition and relevance, how to evaluate for fluid responsiveness. So now we're going to talk about what to look at, what variables to monitor when you have your hemodynamic monitoring. And that brings us to static versus dynamic parameters. So it's been thought that static parameters like your blood pressure, your central venous pressure, and your pulmonary artery wedge pressure they pretty much give you a snapshot of what's going on with a patient at a specific time period. Whereas a dynamic parameter gives you more information. It tells you what a patient's physiologic response is to an applied stimulus, such as volume resuscitation. So it tells you if I give volume to this patient, the patient will react like this. It will either improve with stroke volume or not improve with stroke volume. So more experts are recommending that we move away from static parameters and focus more on dynamic parameters. So examples of the dynamic parameters are your pulse pressure variation, stroke volume variation, and you can also get a lot of parameters from point of care ultrasonography as well as with passive leg raising. So it's important to keep in mind the heart and lung interaction. Like I'm sure you already know, during spontaneous ventilation, the heart responds differently than when the patient is under positive pressure ventilation. So with positive pressure ventilation, with inspiration, your intrathoracic pressure increases, which causes your right atrial pressure to increase and your right-sided afterload to increase. And that, as a result, causes venous return to decrease. However, there is a fairly long pulmonary transit time of blood, right? So it takes a while for the blood to go from your right side of your heart, go through your pulmonary vasculature, and then go into the left side of your heart. So as the venous return is decreasing, you don't notice it. The venous return is decreasing on the right side. You don't immediately notice it on the left side until during expiration, which is, again, because of your pulmonary transit time of blood. So, you have to keep in mind when you're evaluating patients, you want to be looking for the magnitude of changes. How much change is my pulse pressure having during inspiration versus during expiration? So the next slide talks about pulse pressure variation. So what is pulse pressure? It's your systolic blood pressure minus your diastolic blood pressure. And your PPV, pulse pressure variation, is your maximum pulse pressure minus your minimum pulse pressure divided by your mean pulse pressure. And again, there's variability during inspiration and expiration because of the heart and lung dynamics. And studies have shown that those with a high PPV are usually at the bottom part of the Frank-Starling curve, meaning they're usually at the fluid responsive portion. So if you have one of those tools that I talked about and you get a PPV of 13 or more, that should mean that they are fluid responsive. Whereas those who have a PPV of less than 13 are usually not fluid responsive. So they're on the flat portion of the Frank-Starling curve. If you have patients with PPV less than 13 and they're in shock, you might want to consider vasopressors because additional fluid is unlikely to be helpful. And stroke volume variation is pretty much similar. SVV is linearly related to pulse pressure, and you get it by saying your maximum stroke volume minus your minimum stroke volume divided by your mean stroke volume. And again, patients with high SVV are at the bottom part of the Frank-Starling curve, so point A, and it means they are fluid responsive, versus those who have SVV of less than 13. They're usually on the flat portion of the Frank-Starling curve and less likely to be fluid responsive. And this was a study that was published by my mentor, Dr. McGee. And multiple studies have shown that SVV and PPV correlate with fluid responsiveness. So this study published by Dr. Marek in 2009 showed that the sensitivity for PPV is 89% and specificity was 88%. And the sensitivity for SVV was 82% and specificity 86%. So pretty good in terms of determining fluid responsiveness. And this other study published by Dr. Biasis showed that SVV and PPV had even greater specificity when compared to wedge pressure and CVP. Again, that has to do with the fact that wedge pressure and CVP are static parameters. They give you information on a specific time point, whereas SVV and PPV give you information about a dynamic response. So let's see. It sounds great. Why don't we use it on all our patients? Why is it not the standard of care to evaluate for hemodynamic variables, PPV and SVV? And it is because it has some limitations. It is limited to patients who are mechanically ventilated and in patients who are receiving at least 8 cc's per kilogram of tidal volume. So that already takes out a lot of our patients, especially during the COVID area. And these patients should not be spontaneously triggering the ventilator. They should also be in sinus rhythm with no arrhythmias. So again, takes a lot of our critically ill patients out of the picture. And the other things you could look at is point of care ultrasonography. There are lots of, I love my echo so much. And there are lots of measures you could obtain. There are a lot of variables you can obtain with your point of care ultrasonography. One of them is your vena cava assessment. You want to look at the size of your IVC during inspiration versus during expiration. And you're really looking at the magnitude of these changes. So again, you have to keep in mind that with spontaneous breathing during inspiration, your IVC will collapse, right? That's because you have negative intrathoracic pressure, which causes blood to go from your IVC into your heart. So your IVC collapses, whereas with positive pressure ventilation, the opposite happens. There's increased intrathoracic pressure with inspiration, which pushes blood from the heart into the IVC, so your IVC distends. But what you have to look at is the differences in the sizes. This is how plump does my IVC get during inspiration versus how much does it collapse during expiration. So if it's been shown that if the change in IVC diameter is between 12 to 18%, then it's been associated with fluid responsiveness. And this has been found to have a 71% sensitivity and a 75% specificity. And this is something you can do at bedside. It's non-invasive. You don't need to do any procedures. Just put the probe on the patient and take it off when you're done. And with your point of care ultrasonography, you can also look at other assessments. You could do a lung ultrasonography. If you have a patient in shock who has received 4 liters of volume and still in shock, and you want to ask yourself, can this patient tolerate more fluids? You can look at the lungs. If there are B lines, then it will indicate pulmonary edema, and you don't want to give that patient more volume. But if there are no B lines, if all you see are A lines, you can say, okay, I can try more fluids and see how this patient does. You can also look at Doppler of portal, hepatic, or renal veins. Pulsatile flows in these vessels may be used to assess volume tolerance. And you can also perform a passive leg raising test. So there are going to be some patients who you're very worried about giving any additional fluid, but you suspect that they could be fluid responsive. So what can you do? You can just bolus them their own intravascular blood. And that is, you sit them upright at 45 degrees and measure your hemodynamic variables. So you can, depending on what tool you have, you can get a cardiac output, a stroke volume, and then you lay them, put their head flat and keep their legs elevated at least 45 degrees. Keep them in this position for 1 minute. And then we measure those variables. So check your cardiac output and stroke volume. If there is a 13% increase, then that will mean that they're fluid responsive. And you can go ahead with giving them fluids. So those are the hemodynamic variables to look at, static versus dynamic parameters. And again, very briefly, I'll talk about tissue perfusion. It's been suggested that microcirculation might be a better way to assess for shock and assess for volume responsiveness. So macro circulation are things like your blood pressure, cardiac output. It evaluates blood flow in your large vessels. So your vena cava, your pulmonary artery, your aorta. And these values may be normal early in early shock. Whereas if you were to measure microcirculation, which is at the tissue level, you might be able to diagnose shock earlier and therefore diagnose volume responsiveness when patients start improving. So you can look at a way to evaluate for microcirculation. One of them is the NAIRS. It's called NAIR infrared spectroscopy, which measures tissue oxygen saturation. It does have a lot of limitations that I'm not going to go into. You can also measure microcirculatory blood flow by looking at the sublingual microvasculature. I have a picture of it on the next slide. And you can also check your lactate and capillary refill. So this is the measurement of microcirculatory blood flow. You have a handheld vital a microscope. You put it underneath your tongue. You look sublingually, and you look for shedding of the glycocalyx layer, which will indicate inflammation. And during shock, you have completely damaged endothelial glycocalyx layer. So I have no experience with this, but some ICUs here in the United States use it. And lactate versus capillary. So this is helpful in resource poor settings. So this is a study that was published, Andromeda shock study was published in 2019. It looked to see if the use of capillary refill time is a possible alternative to lactate as a resuscitation target. As we know, evaluating for lactate clearance is used quite commonly as a resuscitation target. And this study showed that you could use capillary refill time as a resuscitation target. So that's pretty much your good old physical exam. If you have none of these tools that I've talked about, and if lactate is not available to you, you can settle for a physical exam, look to see if that's improving, if the capillary refill time is improving as you're given volume resuscitation. And that is pretty much all I have. Now, before I go into my knowledge check questions, I want to see if you guys have any questions for me.